So very good evening to the audience. Thank you for the previous speaker for the wonderful talk. It was all high five for me. And my talk I will try to keep it very short and sweet. So the talk is what, when, and how in diabetes management. What I will be discussing is need of talk. It will be followed by practical interactive session followed by summary. So before I begin my talk, as this famous saying goes by Mr. Harold, who was Commerce Minister of Antigua country state. Politics is who gets what, when and how. And we have a similar saying in medical field that a good clinician is one who knows what to do, when to do and how to do. So I have tried to take this talk on the similar lines. There is also additional thing that we also should know what not to do, but I'll keep it for some other day.
Please maintain silence, please. All of you.
Why I've chosen this topic, why I kept name like this is I would want to start with one surprising fact. What is the status of diabetes management in today's world? This was very one good study, old study in 2011 in Indian Journal of Endocrinology and Metabolism. We are in 21st century, we have all the new molecules which are getting launched left, right, center. The best of the insulins, the insulin pens, CGMs and whatnot. In spite of that, what is the average HbA1c of Indian patients? It is 8.9, very pathetic control, what we call poor glycemic control in medical language, with a random blood glucose of 193. So only 19.7% of people with type 2 diabetes have a good glycemic control in India. This was 2011. In 2021, the figure has gone merely by 6% to 25%. That means still 3/4 of patients do not have a good glycemic control. Now I was going through some literature search why this is the case. And that's why I've chosen the name of the topic and going to have a flow like that, what, when and how. So what I thought, many of the things are my personal take. Let me first raise my hand for that. Few things are definitely backed by scientific data. So what happens is for any field we have a existing knowledge. जब हमारी डिग्री पास करते तो बिल्कुल टेक्स्ट बुक से सीख के करते ये करना है ऐसे करना है वो करना है. But when we pass out and then start our clinical practice, depending on which area you are practicing, what are the personal and financial constraints of patients, social and economic strata, religious beliefs and acceptance, we develop certain traits in practice. So actual practicing traits are different than the existing medical knowledge, which leads to the gap. To compound the issue, as we say, medical field is ever-changing subject. So what happens is the changing concepts and the expanding knowledge still does not change much the clinical practicing traits, and that further widens the gap. So this is the reason as far as diabetes part is concerned, because my talk is on diabetes. This is what I feel is the reason for poor glycemic control in India. So that is why I have decided to take a topic of what, when and how. Very simple, what to do, when to do and how to do. Now before actually going to talk, so I did mention that I am going to have an interactive session. So I didn't want the audience to go to sleep. So when we are driving, we know that we don't like one ways. If it is two way, it is always better. So this is going to be an interactive session where I would like you all to concentrate and give me some responses so that we can discuss, and then later on I will give you scientific inputs It may be wrong, your answers may be wrong, doesn't matter. Here we are all here to learn, and collectively you and me would want to come up with some common issues, common practicing principles which will help you that irrespective of specialty. I am very sure that whether it is a broad specialty or super specialty, we do get diabetes patients. So very basic, any person can manage diabetes, but when we start in the beginning that from the diagnosis, basic treatment, there should be no mistakes. So that is why this is the session. So coming to first case, about what, like I said, a 50-year gentleman was diagnosed to have diabetes based on glucometer readings of 220 milligram per cent. He was asymptomatic and had family history of diabetes in parents. He was referred for evaluation. So what to do? So the options here are check random blood glucose on glucometer and adjust medication dose. Check fasting glucose, postprandial glucose and HbA1c in laboratory. Check fasting glucose, postprandial glucose on glucometer and adjust medication dose. And check HbA1c on point of care test. So I would like to invite answers from audience. It may differ, doesn't matter. So anything, anyone would want to have a go at it. What should be done? Option 1, 2, 3, 4, 2. Very good. So that's a correct answer. Now why I have taken this example, what to do is I see a lot of patients and also doctors asking the patient to, first of all, as far as patient part is concerned, a lot of patients do come, मेरी मम्मी को डायबिटीज है, पिताजी को डायबिटीज है, घर पे मैंने शुगर चेक की, 180 आई, 200 आई, so I thought I am diabetic. Without checking any or confirming glucose, patients are even started medicines. So that is absolutely what I should say incorrect practice. Now I will talk about what is the scientific data, the guidelines per se. So the learning point here first is diagnosis of diabetes requires 2 of the 3 tests to be positive. So diagnosis of pre-diabetes is different and diagnosis of diabetes is different. If somebody gets the blood sugar of fasting more than 100 to 125 and BP of 141 to 199 or 200 will be called as pre-diabetes, or even HbA1c of 5.7 to 6.4. But if you have just one HbA1c of 6.7 and fasting sugar of 90, I am not going to call you a diabetes patient. So there I have to have 2 positive tests, or the test whichever is higher should be repeated. So 2 different occasions. Do not declare the patient to be diabetic. This is the most important thing what I see in my practice. So like I mentioned, the topics what I have chosen is based on being a super specialist. I do get a lot of references, patients. These are the ways I am dealing with the patients in my clinical practice. So I thought at least I should discuss about basics, but I am happy that all the answers were right for the first question. Second point is point of care testing is not validated for diagnosis of diabetes and also for monitoring as well. So many patients who are on oral anti-diabetic medications do not do any blood test. Last blood test कब की थी 1.5 साल पहले. नहीं जी वो तो घर पे शुगर चेक करे, शुगर बढ़िया है 90-85. Nowhere in the books it is said that glucometer sugar should be used for diagnosis, for prognosis, for management, for changing dose or deciding dose. It has to be fasting PP in the laboratory. So that should not be done. And HbA1c, I see a lot of point of care tests. Strip वाले HbA1c भी काफी labs में किए जाते हैं, which are absolutely wrong. So HbA1c has to be done by HPLC method, and it should be even that HPL assay should be certified by NGSP. So this is the learning point for first case. Second case is a 56 years lady. Yes, sir.
Why are you emphasizing upon the blood test being recorded from the laboratory and not by the glucometer at home?
That is what I said. Any test has to be validated. Glucometer is not validated. We have got n number of studies. For example, when I say the diagnosis of diabetes is called when the HbA1c is 6.5 plus, or fasting glucose of 126, or PP of 200. So there is no corresponding glucometer value which is validated. That is why it is not used in diagnosis. So you have got many studies, the famous one being that somebody used to say, there are two great studies which have said that, say, glucometer fasting glucose 110 can be used, but again, when that was corroborated with the laboratory, it missed many diabetes cases, and that is why it is not standard. So glucometer at best can be used as a screening tool, certainly not as a diagnostic tool. Case number 2, a 56 years lady with type 2 diabetes on oral anti-diabetic medications was admitted for acute febrile illness. Her blood glucose levels were fluctuating in hospital in spite of addition of insulin. What to do? I think it's very easy, but like I said, I'm getting a lot of different practicing trends, so that's why I decided to take this example. So the options are stop insulin, stop oral anti-diabetic medications, adjust dose of insulin, and adjust dose of oral anti-diabetic medication. Anything? Any answers? So that's the correct answer. Now, why I have chosen this example in learning point is in most patients, these are the standard guidelines also, this is what we see in clinical practice also. In most patients during hospitalization, insulin is the preferred therapy because the titration of treatment is easier with insulin. So patient cannot be taking food because of stress, fever, trauma, illness, surgery. Sugars might be fluctuating, glucose might be fluctuating. Now, if you give medicine, if the patient does not take food, if you give medicine and patient is suddenly shifted to sonography or CT scan, patient misses the meal in the ward, and then patient lands up in hypoglycemia. So there is no question of giving oral antidiabetic medication for most of the patients. If the admission is for a certain diagnostic workup and you know that patient is going to get discharged in 1 or 2 days, absolutely no stressful situation, you can continue whatever oral antidiabetic medication. Otherwise, in selected individuals with mild hyperglycemia, only DPP-4 inhibitors can be used. But important point, what I want you to take home message is absolutely no oral antidiabetic medications. I have seen that even in ICU, when the patient is on non-invasive ventilator, patient is being given oral diabetic medication. मैंने पूछा कैसे देते हैं, बस 2 मिनट के लिए मास निकाल लेते हैं when the patient saturation is already 65% with FiO2 of 1. So that is absolutely incorrect way of doing that. So no oral anti-diabetic medications in most of the hospitalization. I'm not saying all. Now case 3, a 55-year gentleman with type 2 diabetes on oral anti-diabetic medication had mild derangement of liver enzymes, AST 35, ALT 40. Patient's HbA1c was persistently high, that is 8%. Patient consumes occasional beer once in a week. So what to do in this patient? So counsel about alcohol abstinence and repeat enzymes after 1 month. Intensify diabetes treatment. Evaluate for NASH and ask for USG abdomen. Any right guess? Absolutely correct. So evaluate for NASH. Now why I have taken this example is like I was mentioning in my second or third slide, the changing concepts. This is new in 2023 ADA guidelines that any amount of alcohol history, and obviously if we see the liver enzyme derangement, we would first want to correlate with alcohol-induced hepatitis or liver dysfunction, whatever, and we will certainly not label that patient as NASH initially at least. But now a patient in case of males, that is gents, if it is more than 21 drinks per week, and in case of ladies it is more than 14 drinks per week, then only you should think about alcohol-induced liver dysfunction. So that's why this example, these are not good examples, these are all the jail patients I have seen in OPD. So this gentleman was only having once in a week beer, which does not qualify to be called as alcohol-induced liver dysfunction. But other point what I want you to take home is how it is important or relevant to diabetes is, for me, this job is to be done, so I will refer the patient to hepatologist. The other practical implication in terms of treatment for me is, or other thing is, So our answer is evaluate for NASH, that's correct one. So NASH is present in more than 50% of diabetes patients. And evaluation of NASH in patients with deranged liver enzymes in the absence of significant alcohol intake is necessary, that we have seen. And for me, how it changes is NASH has an important bearing on the treatment decision of diabetes. So for NASH, as you know, very few medications are useful. We do give vitamin E and then statins and many things. So except statins, I think there is nothing much valid. But for me, as a diabetes patient, I did mention, I'll just go back to this slide. So this patient also had uncontrolled glucose, HbA1c of 8%. Now this patient is an ideal candidate to start GLP-1 analog. So GLP-1 analogs have been known to reverse the changes of NASH in many, if not in all patients. And also at the same time, I may get a better control of HbA1c if the patient can afford. The second point which I have not written in learning points is liver enzymes 35 and 40 is not very high. But now the guideline is any diabetes patient, two persistent occasions, AST-LT values of more than 30, think of NASH. Because the incidence is really very high than what we think. So that is why this was what I wanted to convey, that NASH had a very high level of priority. Next point, next case, a 45 years lady with type 2 diabetes on oral anti-diabetic medications and insulin presented with rapidly increasing insulin doses. Patient's HbA1c was persistently high in spite of multiple changes in medications. So what to do? Assess exercise compliance, assess insulin technique and educate the patient, start GLP-1 analog therapy and assess diet compliance. Anything? Very easy that way, but yes. So assess insulin technique and educate the patient. This is also very important what I see in practice. Insulin is started and at least to me whenever the patient comes, if I am starting for the first time, I ask the patient, are you aware about insulin, how to take it? There are 6 to 7 points. You should be knowing that. So something called as insulin injection education. You will be surprised that many patients take insulin at funny places. Somebody takes an umbilicus, somebody takes it on a calf muscle, somebody takes it on the wrong side of the thigh. So all funny things, and this is one of the most important causes in insulin patients for uncontrolled glucose. We keep on thinking about, so of course compliance and diet and lifestyle definitely comes into picture. But the first thing what I have seen in my practice, I have to just ask, are you aware about how to take insulin? If not, I educate that. More than 80% of patients in next visit, I see the drop in blood sugar drastically. So education technique is very important. So insulin injection technique assessment is of paramount importance. Incorrect method, timing, site of insulin is responsible for significant of patients in poor glycemic status. And then how to educate. So I do educate. Otherwise, it is a good practice to employ a diabetes educator if possible. But that is possible in centers, higher center. And about what, last case for what. A 47-year gentleman newly detected type 2 diabetes was started on medications after investigations. What to do next? So ask for follow-up after 1 month, refer to dietitian, counsel about exercise, diet and refer to diabetes educator for general information of diabetes. And no further action is required, you can send on the patient. So any wild? Yes, very easy. So answer seems very easy, but why I have taken these examples are I rarely see any patient being counseled like that. So the learning point is what I want to convey is diabetes, what we call as 4 pillars. Diabetes management, that is diabetes education. So I make it a point to discuss with all the patients in first visit itself about various aspects of diabetes. Then there is medication, then there is diet and exercise. All 4 are equally important, should be discussed by a treating consultant, at least physician and endocrinologist definitely. But unfortunately what happens is we concentrate only on medication part, and this leads to uncontrolled glycemic status in most of the patients. So this is about what? Now coming to when. A 28-year pregnant lady was referred for evaluation of increased fasting and postpartum glucose at 20 weeks gestation. She was advised to start anti-diabetic medication When to start medications? After doing HbA1c immediately, after doing GTT immediately, after doing GTT after 6 weeks, and after repeating fasting and postnatal glucose immediately. So, any case? 2. Anyone else? 4. Okay. So, the answer is 3. This is a clear-cut guideline. This is one of the most commonly wrong done things which I see that first of all, fasting BP sugar is done, or it is done at the wrong gestational week, which is so we diagnose for a pregnant lady to have diabetes at 2 times. One is immediately after conception, and second is between 24 to 28 weeks. There is no other time. And also to method to diagnose is 75 grams glucose tolerance test, no fasting BP glucose. So that is not validated, all clear cut, all guidelines say that. Of course, I am sure if any gynecologist is sitting here, they will might little disagree because you have got one step test and 2 test where you ask the patient to come non-fasting, just give 1 shot of glucose and check after 1 hour. If it is more than 140, you label as this thing. So that's fine, but I'm discussing about the standard guidelines. And we can have a pregnancy with diabetes as a separate talk because there are a lot of controversies in that. But I just wanted to draw attention that timing, at least timing, how to do it, whether only HbA1c is good, fasting BP is good, GTT is good, we can discuss. But timing, certainly don't label somebody as diabetes at 14 weeks, 18 weeks, 36 weeks, 32 weeks. It's only during 24 to 28 weeks. Next is a 46 years lady is to undergo cholecystectomy. She is non-diabetic on oral anti-diabetic medications. Her random glucose in clinic is 281. She was referred for fitness. Can we go ahead with the operation? So more relevant for surgeons. When can she be operated? So immediately after changing anti-diabetic medication, 1 month after controlling blood glucose, 3 months after controlling blood glucose, and immediately after switching to insulin therapy. Okay, so I'm talking about the ideal answers here. So the answer here is 3. That is because this is what I get reference to. So first of all, the parameter to decide fitness in an elective case. I repeat, the parameter to decide for fitness in an elective case is HbA1c, not blood sugar. If it is an emergency, like somebody is having a heart attack, or if somebody wants to undergo PCI, CABG, sugar doesn't matter. I will have to admit, I will have to start insulin and operate. But elective surgery, it's only after control of HbA1c we give fitness, because what happens is after changing medication within 3 to 4 weeks, some surgeons do operate. If your blood sugar is controlled, the reason for that is the chance of complications, infection, everything is more if HbA1c is high, because HbA1c indicates chronic hyperglycemia. So within 2 weeks also, if your fasting BP sugar is good, the term used in textbooks and guidelines is tissue effects of hyperglycemia do not go or reverse till 3 months. So if somebody's HbA1c is 9, sugar is 281 like this, I change the medication, within 15 days I can get her or his sugar down to 90 fasting and 130 or 140 pp. Then if I give fitness, maybe 9 out of 10 times patient will go home successfully, but one patient might have very bad complication, and that one patient can destroy your practice. So for us, whenever there is a fitness call or fitness referral, we always tell the patient that it is surgeon's call to decide what is the necessity for the operation. If the underlying condition demands, like mature cataract, heart attack and CABG, like I said, sugar doesn't matter. With 2 also I can operate, because life is first important, patient should survive. But in an elective case, no question of giving fitness till HbA1c is controlled. This is the take-home message. Next case of 48 is lady with type 2 diabetes on oral anti-diabetic medications had fluctuating glucose levels and high HbA1c. She was advised CGMS. So everybody is aware about CGMS machines. When to start CGMS? So options are immediately, 3 months after changing medications, after admitting for glucose control, and not required. Okay, so CGMS can be equated with home monitoring of glucose on glucometer also. So I wanted to talk more on that point. So in my first example also I said that a lot of patients are asked to measure glucose at home on glucometer. So answer is not required. So even CGMS and glucometer monitoring is not required for patients on oral antidiabetic medications. It is only for patients on insulin. Now before sir you ask question why, I would like to give an answer that because it has been found that let's say if you monitor for 5 to 6 times on glucometer, the problem is readings don't translate into better glycemic control unless you take action. Now, a patient who is on oral antidiabetic medication would check maximum 2 to 3 times. One reading is 180, next reading is 80, third reading at 90 is 211. Are you going to change or is he going to change the medication? No. Does the patient practically change the diet according to the readings? No. So, minimum thousands of studies have seen that patients were asked to monitor glucose and asked to report so that they can be counseled about diet. But even after counseling sessions, they don't take any action, so it results in negligible change. To be precise, 0.1% change in glycemia. That's why, except insulin, where obviously the levels are very high, that is the reason we start patient on insulin. On oral antidiabetic medication, no CGMS machines and no glucometer monitoring. Next, when to advise of 35 years gentleman recently detected to have type 2 diabetes on oral antidiabetic medication, came for follow-up with reports of fasting and PP glucose. No other investigations were done. When to advise other tests. So ask for all tests immediately, ask for blood test after 6 months, ask for blood test after the control of glucose, and ask for blood test only if patient is symptomatic. Yeah, so very easy one, but still, surprisingly, why I have taken this example is more than 80% patients do not have the tests with them, even with the history of 10 to 12 years of diabetes. The learning point here is, everybody knows, just to recapitulate, occurrence of complication is a later event because that is what patient says कि अब कहाँ आंखें खराब है, किडनी में क्या है, मैं तो ठीक हूँ, पेशाब ठीक से आ रही है, why should I do creatinine, why should I do LFT, why should I do lipid profile, क्यों पैसे खर्च करने? And even this is the questions from consultants on phone when they refer the case, अरे आप पेशेंट की इतनी इन्वेस्टिगेशन क्यों करा रहे हो? So the answer here is the landmark DCCT and UKPDS trial and DCCT trial have already proved that on the first visit itself, when the patient gets to have diagnosis of diabetes, there are so many complications on day one. So 3% intermittent complications, retinopathy in 21%, hypertension in 35%, erectile dysfunction in 20%, so on and so forth. And that is why we should act as soon as diagnosed. Complications have already begun even before you understand the disease. That is why first visit, no patient gets diagnosed to have diabetes. Just don't start anti-diabetic medications and send home. Ask for at least basic 3-4 things if possible. So this we all know that what is the basic evaluation for diabetes patients. So next, a 16-year boy recently diagnosed to have type 1 diabetes based on ketoacidosis, osmotic features and high glucose levels. When to advise antibody panel test. Now this is again something that third slide I will remind you. I was talking about few new things and changing science. So I am very sure that not many of the pediatricians would do antibody tests because those are very costly. So when we should do those tests? Not required as they are of only academic interest. Advise in all patients if patient is willing and no financial constraint. Advise after 6 months of diagnosis and advise immediately during hospitalization. Yes. So we should advise, but the reason is, now there is something called as antibody positive type 1 diabetes and antibody negative type 1 diabetes. But more important than that is, all type 1 diabetes, age no one. Around 20% of patients are wrongly diagnosed to have type 1 diabetes if we do antibody panel test. This is recent February 2023 new paper analyzing 776 type 1 diabetes patients from different centers. Nobody had done the test, and they asked the patient to undergo the test at the center, which was obviously funded. And they found that 30% of patients actually had type 2. So that was stopped. And also, the other practical implication is, I'm sure all pediatricians will agree with this. If you start insulin, first question is, Doctor, insulin कब तक चलेगा? क्या कभी ये बंद होगा? Based on theoretical knowledge, you can answer, but if you want to have a solid evidence, so type 1 diabetes who is antibody negative, there is a very high chance of withdrawal of insulin. Now, how to advise? This is the last part. The 36 years lady with history of diabetes on 4 oral anti-diabetic medications had uncontrolled glucose. Patient asked for diet advice. How to advise? I have done a few changes. I will not tell you now what changes I have done. Now, after this, I'll talk about something that I'll tell you what changes and why I changed, why these changes are done in this slide. So, how to advise the diet? So, advise to stop sweets, give standard diet chart, take detailed diet history and counsel, and advise general do's and don'ts. So, any answers? No, that's wrong. Definitely, certainly not the first one. But yeah, answer would be advise general do's and don'ts. I've done a slight change here, like I mentioned. Now, diet part, yeah, obviously we have to give a standard diet chart and send the patient to dietitian. But how to advise? Here, what I have done is, there are some practical tricks which we were taught, and apart from endocrinologists who have to do this by profession, other specialists can definitely finish the job in 2 minutes. How to do that? So, how to advise about diet? So, this is what we were taught. So, diet discussion nobody you can finish because everybody said, क्या बात करेंगे? पहले diet history लो, फिर ये मत खाओ, 1000 questions आएंगे. How to finish off in 2 minutes? So, diet discussion nobody should be done. There is a simple mnemonic for that, no PFFs. So, provident fund you can remember. So, no PFFs. So, what does it mean is, N for non-veg, discuss about non-veg, oils, proteins, fruits, fibers and sweets. So, these are the common questions asked by patients. कि कौन से फल खाने हैं, क्या मीठा खा सकते हैं, ऑयल कौन सा लेना है, ऑलिव ऑयल लेना है, पाम ऑयल लेना है, तिल का ऑयल लेना है, वगैरह वगैरह. So, if you discuss these points, you can finish the job in 2 minutes. So even 2-minute discussion about diet is shown to improve glycemic control in 40% of it. This line is not mine, this line is from the famous paper. A 10-year-old boy, type 1 diabetes for 6 years, came with history of fluctuating blood glucose with multiple hypoglycemic episodes during acute febrile illness. How to address the issue of glycemia during illness? I think pediatrician will easily answer this. So order CGMS at home, ask to stop insulin to prevent hypoglycemia, assess compliance and adjust insulin dose, and refer to dietitian for carbohydrate counting and adjust insulin dose. So any wild guess? Yes. So answer is assess compliance and adjust insulin dose. No, this point I have taken because again just to repeat in one line for everyone. Any type 1 diabetes come is big of specialty, especially when the patient is sick. How to take care of themselves at home and when to approach a doctor. So everybody must have learned in MBBS something called as sick day rules. Now sick day rules are many points. We can't keep discussing so much with the patient. So then for there also we have a how to go about that. So we were taught. So all these are what teachings you will not find in any books. So KHC we used to use for mount or making slides, fungus slides. So KHC you can remember KHC. So ask the patient to check ketones during illness, ask the patient to maintain hydration and compliance of the treatment. The most common mistake is patients stop medications, especially insulin, thinking that patient is not eating well, तो insulin लगाने से क्या फायदा? And that is the reason why patient ends up in ketoacidosis because sugar zones past 400. So, a 58-year lady with type 2 diabetes on insulin and oral diabetic medication presented with pain and difficulty in walking in right lower limb. She had no fever, ulcer, deformity. Lower limb was swollen, warm with red skin. How to do triage of foot problems in OPD? Now again, this is one very headache. Foot ulcers are a very common problem. So assess glycemic status and decide. Assess neurological vascular symptoms and decide. Assess systemic symptoms and decide. And assess podia scan report and decide. So the answer is assess neurological vascular symptoms and decide. Here also you can do a simple triage. कि कौन से patient को detailed evaluation चाहिए, because all foot investigations, like if you want to do color Doppler, nerve conduction study and all, those are very costly. So how to do a triage of patients? So detailed evaluation required, IUD, NM. So ischemia, ulcer, deformity and neurological motor symptoms. Definitely patient is serious. Don't send the patient home and evaluate. Whereas it is only NSR, that is neurological sensory symptoms, and only regional symptoms, you can try to treat symptomatically and assess. If required, you can admit and evaluate. The only respectable exception would be Charcot. A 66 years lady, a case of type 2 diabetes on oral antibiotic medications came for follow. How to assess completeness of diabetes evaluation and OPD. So by doing symptom-based lab test, by assessing glycemic control, by maintaining the checklist, and by doing complete examination, a very simple one. Again, the previous question is a repetition, but basically it's by maintaining the checklist. So very simple checklist what we used to follow. ER, that is emergency room, and LVF, left ventricular failure. So in any patient, even if you ensure that these things are done, your job is done. So E for ECG, R for radiology, that is UHG scan, for checking pancreas and liver for fatty liver. Basic lab test. Vaccination is very important. So for all elderly patients with diabetes, we might treat, but we forget about vaccination. So pneumococcal vaccination is very important. And fundus, that is retina. So this test is very important. And final case, an obese 50-year businessman, a case of type 2 diabetes on oral antibiotic medications, and usually with poor glycemic control over last 2 years, and willingness to control glucose came for follow-up. How to approach such a case? So enroll under and strictly monitor diet and exercise program, intensification of OAD and insulin therapy, advise bariatric surgery, and intensification of OAD, insulin, diet and exercise or. Now this is the most important last slide, I have kept it for that. Any answers? Okay. So answer is bariatric surgery. Why? I will explain. You can have fourth option also, but please look at the case. Obese person, businessman, so no financial constraint, willingness for control of glucose, all three factors. But what do we mean by control of glucose? So the recent hot topic, again I will go back to third slide, I mentioned something new. So almost 30 to 40% of patients are eligible for something called as reversal of diabetes. Now this is a very hot topic of today. What do you mean by reversal? So reversal is a state where patient has a good glycemic control without medications for at least 6 months. Can it be achieved? The problem with current diabetes treatment is current healthcare in the area of lifestyle related disease like diabetes does not focus on reversal. We just try to think about cure or treatment part. So we treat with different modalities. But wherever possible, diabetes reversal should be tried, and that is why in this patient, we all know that bariatric surgery can achieve a reversal of diabetes. That is the most successful treatment available for reversal, more than any insulin and GLP-1 analogs and medications and all. Reversal, whenever possible, should be targeted and achieved. So that is why in this patient, I would definitely advise for, and of course this patient did undergo surgery. He was on basal bolus insulin comprising total 120 units of insulin, 6 oral anti-diabetic medications. After bariatric surgery, he came to only one metformin 500 in the morning. Everything gone. So that also fits into the criteria of reversal. So it's not only about treating diabetes, it's about reversal whenever possible should be done. So what is the summary of my talk? A diabetes patient in OPD, either new or old. First part of my talk was what to do. So what to do? Confirm diagnosis, start appropriate treatment, discuss regarding diet, etc. and assess comorbidity and risk stratification. For all this what to do, we have standard practicing guidelines. And that's what I mentioned. Mostly you cannot deviate from that. You can't use glucometer, you can't send the patient without diet, you can't do HbA1c or fasting PP in pregnant lady. You have to follow what is standard. Otherwise diagnosis is wrong. Second part, when. So diabetes patient in OPD, when to give dietitian reference, when to do diabetes education, when to order blood test, when to give fitness for surgery, so on and so forth. There also we have standard practicing guideline based approach. You cannot deviate from that. And coming to last, dealing with problems like foot ulcer, uncontrolled glucose, deciding diet plan, etc. How to do that? Now there we do have standard practicing guidelines, but from 2014 onwards, the major change in diabetes management was the diabetes management has to be patient-centric. So we can't enforce. And that should be done after collectively discussing with the patient as a diabetes team. So it's like the example what I give is, you have to reach from here to Delhi, you have 10 ways. You can go on your feet and you can go to airplane. That doesn't matter how to reach. Or the other example is, if I ask the patient to solve a sum, you can have 10 to 15 ways to solve a sum. I want an answer. I can't ask him to just muck the sum and then solve it. So solving is important. Similarly, the goal of our discussion today, the topic is, we want to have a good glycemic control in patient. What and when is clearly defined. How to do? You have a large freedom, but that freedom only if you are able to achieve a good patient care, not at the cost of good patient care. So, as they say, study hard until one day you can say, trust me, I'm your doctor. That is what the purpose of this talk. Thank you for patiently listening.